For those patients who might be at higher risk of recurrence, like you just said, the positive nodal status or non-PCR patients, what are the options? What options do they have to minimize the recurrence risk?
Yeah, this is excellent. So, I mean, we would need for those patients with high aggressiveness or residual disease mechanisms of action that have not been used before, so that we do not know that we have a resistance from. This would be for non-PCR patients, of course, would be Kadcyla if it is available, and then a TKI using another mechanism of action, so binding to the intracellular domain. And we've learned that neratinib as a pan-HER TKI is very effective as an extended adjuvant treatment. This is my idea. Of course, if we have triple positive disease, we would use this in combination with endocrine treatment.
Thank you. And you just said the tyrosine kinase inhibitor, the neratinib, which I am personally actually very interested in, because I haven't had used this drug on my patients yet. And what my concern is that the Adjuvant trial is actually conducted in the pre-pertuzumab era, and also in the era where we didn't have TDM1 as an option for the post-neoadjuvant non-PCR patients. So does that bother you? And nowadays, in your daily practice, in what context would you consider neratinib? Or what kind of patients would you consider adding on neratinib as their treatment options? And how do you explain the risk and benefits to them?
Excellent questions. You started your question with, does it bother me that this was done before the pertuzumab era? Of course it does, because I would love to have data with all these treatment options. And in fact, we do have these data now from the real world evidence. Like in Germany, I'm the principal investigator of the Eleanor trial. That is a phase 4 trial, just collecting the data and checking the selection of my German colleagues, how they use neratinib. And in fact, it is really the high-risk patients, even if they have been pre-treated with pertuzumab, and even if they have not reached a PCR and have received TDM1 afterwards. So we know that these patients have a high risk, and it can go up to 30–40% over 10 years, depending on the risk profile, nodal status, and tumor size. And so altogether, we would like to use